Reproductive Medicine of the Free University of Brussels, where he currently works as a medical director. His main clinical and research interests are ovarian aging and ovarian donation and female fertility preservation, both on ovocytes and ovarian cortex cryopreservation. He talked about is there a need for ovocyte cryopreservation, attitudes, and intervention among women? Please, Dominic.
Thank you, Mr. Chairman. Good morning, ladies and gentlemen. I'd first like to thank people from UGEN for inviting me here today, and also want to congratulate Valerie and Rita and all the other people organizing this event, because I think it's a great initiative. The topic I'll be discussing is the question whether or not there's a need to do oocyte cryopreservation. There are three things I would like to discuss. First of all is the background, is the biological, societal, and scientific background to social egg freezing. Then I will move on to the intentions, attitudes of women in the public, so the potential freezers, and then I will move on to our experience in our clinic with the real women coming to our center to freeze their oocytes. So the first thing, the biological thing, is the ovarian aging. We now have IVF ICSI for a long time, and unfortunately many people still think that everything can be solved with IVF ICSI, which is not true. We can solve a lot of problems. We can solve male infertility, we can solve tuber problems, but in the end, what determines the chance of a pregnancy is the age of the woman. And here I present data from our own center, ICSI cycles, more than 18,000 over the years in terms of live birth, and you can see it goes down. There's of course a variation among women. Women with a poor ovarian response, and here I took 5 oocytes or less, they do worse, of course. And women with a normal or a high response can compensate in some way. But what we do see is that at a certain age, from 37, 38 onwards, the chances go down irrespective of the ovarian response. Another problem, of course, is that women of a more advanced age tend to have a lower response in general. So those low responders are more prevalent in the more advanced age groups. So if you look at this data in a statistic way, you see those two factors independently influence the outcome. So just the age, if you look at women of 41, 43, and you compare them to the young reference group, you have an absolute reduction of 20% in live birth chance. And if you add a poor response, you subtract another 16% chance in live birth just for the fact of having a poor ovarian response. We use the same data to calculate the chances of one oocyte retrieved after ovarian stimulation to become a child, because as we start banking oocytes now, we should look at it in a different way. We don't think per cycle, we think per oocyte, because we collect oocytes over several cycles, we pool them, so we want to have an idea of what is the chance that a single oocyte will develop into a child. And what we see here is that you should look at the red one, because this one includes the embryos that are cryopreserved. It also extrapolates the embryos that are still cryopreserved. We have 4 to 5% chance that one egg becomes a child. And then it falls dramatically. It's less than 1% at the age of 43. And also you see here, it falls from the age of 37, 38 onwards. If you do the inverse of this curve, you see how many eggs you need to have one child, on average again, which is very stable up to the age of 37, about 23 eggs. Again, the red line includes the cryocycles, and then they run against the wall. 40 eggs at 40, 60 eggs at 42, and 127 eggs on average needed for one child if you treat a woman at 43. So this actually shows that, explains why women now go to egg donation, so needing the eggs of another woman. With the introduction of oocyte vitrification, we often do it now through egg banking. Second point has been discussed by the previous speaker. It's the laying of motherhood. So more and more women actually run against that wall. And this is data from the UK, but if you look at data of the OECD, every industrialized country is experiencing a delay in motherhood, and what I've learned from the last speaker is that the crisis has made things worse. And these things are also happening in India, China, so the emerging economies. And then the third point is the efficient oocyte cryopreservation, which will be discussed later on by Laura Renzi. So oocyte vitrification has become very efficient, and she's shown, but she will go into detail, that that technique can deliver consistent and predictable delivery rates, even in non-donor population, so the real IVF patients. So these three things explain why we can now embark on autologous oocyte banking. So women freeze their own eggs and use them later on their retrospective timeline. We now speak about fertility preservation. Of course, the great advantage in comparison with embryo cryopreservation, which exists for a long time, is that it avoids the necessity of sperm. And the indications are not only for social reasons, but also for iatrogenic damage to the ovarian reserve, chemotherapy, radiotherapy, surgery, also genetic problems can cause women to have an earlier menopause. Social freezing is a term which is very well known, but we prefer to change the name, to use another name, what we do in our center, and also in Amsterdam, they apparently start using the different name. We use age banking, and age, of course, reflects the age as how old you are, but also stands for the anticipation of gamete exhaustion. So basically, that's what women do. So we prefer that term over social egg freezing. The other terms tend to be very long, so age-related fertility decline or loss are long terms and difficult and not as catchy as a word. So this brings us to our second point, and this is the intentions and attitudes of women in the general public. And therefore, we performed a survey in Belgium where we contacted women through email. And the women were between 21 and 40 years old, and they were from all provinces, all social backgrounds. And we first informed them about egg freezing, the chances, the risks. And then we asked them a lot of questions. Response rate was 55%. And what came out of the study, also mentioned by Thomas just before, is that 3.1% of the women indicated that they would really consider to freeze oocytes. The majority, a small majority of almost 52% said they was not interested. And then there were other people who are in doubt or said, maybe I would consider to freeze my oocytes. So in total, 31.5%, we labeled them the potential oocyte freezers. If you compare these two groups, the potential freezers and the non-freezers, you could significantly see a difference in terms of their age. The potential freezers were younger, more likely to be single and not married, and more likely not to have children, which is quite obvious. We also know that at this very moment, not 3.1% of the population is actually freezing their eggs. So there's still some barriers. And so we asked them what would make it more likely for you to decide to freeze your eggs. And number one for the potential freezer was that it would not damage their own future fertility. Of course, this is a very obvious concern. And therefore, we've done a study, follow-up study in our oocyte donors who also undergo ovarian stimulation egg retrieval. And in the 5 years after donation, we saw there was not an increased risk of experience infertility. So that's not a genuine concern. The health safety of children, of course, is a genuine concern. We have reassuring data so far, but there's no long-term follow-up. And then third is the financial reimbursement. It is still a very expensive technique, especially if you need multiple cycles. Those who decide not to freeze oocytes clearly indicate that you probably already have children or no longer have a desire for children, and that's the reason why, the main reason why they're not interested in freezing oocytes. Third point is our experience with oocyte banking in Brussels. We started egg banking for social reasons in 2009. And basically, it was the patients themselves, the women themselves, who came to us. They said, you freeze oocytes, I would like to freeze them for this reason. So we're not really making any publicity. The demand is really coming from the public. The steps people take at our center is as follows. They start with a psychological evaluation. That's very important, I think, also to gather data too, because we're an academic center, and also to counsel them, to see what kind of women are interested of doing it. And also we do a follow-up study, which we're just actually doing at the moment, to see so many years later, how do they change their opinions and attitudes towards what they've done in the past. Then, of course, there's a medical consultation where we inform them about the treatment, its opportunities and its limitations. And then also very important is the ovarian reserve test. We see if it's still possible for them or doesn't it make sense to do an ovarian stimulation. Sometimes we ask advice of the ethical committee, and then they come back to see the doctor, and then they start their treatment. I think very important is the informed consent. The Americans, the ASRM, have a guideline. The practice committee have published an informed consent guideline, which is very interesting, which you should have a look at, I think, if you start offering it in your center. Also explains what you tell about the patient about the possible chances in the future. But also more recently, the Europeans, the ESHRE, have a paper by the Ethics and Law a task force, which will be very useful in counseling the patients. So who are these women coming in our center to freeze oocytes? The average age at intake is 37. And as you remember from these first slides I showed, this is quite old. Actually, from that age onwards, there's a dramatic decline in chances and oocyte quality. They are highly educated, so 2 out of 3 have a university degree, and most of them are full-time employed. Of course, this probably makes it more likely for them to postpone motherhood, but also makes it more likely to be able to afford the treatment. Most of them Dutch-speaking, and that's because many of them come from the Netherlands. There's a lot of cross-border care in our country. Obviously, most are single, so more than 70% are single, but also 1 in 8 has an ongoing relationship, but still prefer to freeze oocytes. We've seen that almost all women had relationships in the past, or they're able of having relationships, but we also see that many have a very recent breakup. 20%, 1 in 5, has having some sort of therapy. Few have children already, and 13% once had an abortion before in their life. Now, their child desire, also very interesting, I think. So 44% said always have had a desire for a child, while 15 or almost 16% says they never had a really outspoken desire for a child, which I think is strange. But anyway, it shows that they're very rational. They are aware of the aging, and they are aware that they may one day have that desire and then want to be able to fulfill the desire. We also see that most desire a partner. So they desire a partner more than a child. But also 23% desires neither. Again, very rational. They say, but if I would once desire a partner and then desire a child, I want to be able to do so. And the reason why they did not fulfill their desire is then mainly because they did not find the right partner. Only 4% indicates that the career is the main reason. And often in the media, you see that social freezing is because of career. Apparently, our patients do not indicate that. So what is the alternative? They say a more active search for a partner is the only alternative, because all the others are not very popular amongst these candidates, unless the sperm bank. That's number 2. Most of them know that exists because of the media, the internet, and only number 4 is the general practitioner or gynecologist. I hope events like this would change it. Will make the doctors, our colleagues, more aware and more able to explain and inform women about the possibilities and limitations of this technique. I just heard the term assurance, and I think it's a very good term because many see it as an insurance. And many compare it with an insurance like for your house against fire. They say, if I would never have to use these eggs, I don't mind. And the same thing if you insure your house against fire or your car, you don't mind if your car never get a total loss, or your house burns down, because you don't need it. It's just insurance. So it costs money, but we got something back in return, even though we don't always need it in the future. Another thing which is very interesting is that they're still very traditional, because another criticism is very often that they want a more medicalized procreation, because they need to preventively freeze their eggs. But in the end, they prefer still natural conception. So almost 80% say we would first try natural conception, then we would go for IVF, and only in the very end would go for frozen oocytes. And if they would not need their eggs in the future, most would donate for science, but also a certain percentage, up to 15-16%, would donate it, either anonymous or a non-donation. So in total, we had 225 candidates up to September last year, of which 110 are treated, and the others are either undecided and may still start in the near future, or could not start because they were rejected by the ethical committee, or they could not start because of the negative ovarian reserve tests. So if we look at our candidates over the years, we see a sharp increase up to 2011, and you look at the orange, mainly caused by the Dutch. Fortunately, the Dutch have changed the laws in favor of social freeze, because it was not allowed, I think, until April 2011. So most of them could be treated in their own country. So we saw a drop, but this was compensated by increase in Belgians, French, and other EU and non-EU patients. If you look at number of cycles, you would see a drop, but this is not entirely correct, because many of the candidates from 2012 still need to start their freezing this year. If we would eliminate the Dutch population, you can see a sharp increase over time in people coming at our center to freeze. I was also puzzled by the large number of Dutch candidates, especially those from Amsterdam, because 2/3, like in 2011, 2/3 of our candidates were from the Netherlands, and half of all the people from the Netherlands are from Amsterdam, which is just one city in a country with 16 million inhabitants. And may have to do something with the fact it's a city, meant more singles, but there are more cities in Netherlands than Amsterdam only. But also in that center in Amsterdam, they were the first to start to promote or think of oocyte freezing in the Netherlands. So maybe locally there are more in the media, which stimulates women to consider the technique. Another interesting finding is that the average age of the candidates is decreasing. So in the beginning it was 37.5, and now it goes down of only 4 years to under 36, which I think is a good thing. Because especially if you take into account the quality of the egg and the chance of live birth, actually it should go down even more. Ideally it should be between 30, 35 to really have optimal chances of preserving your fertility. The number of cycles women do and number of oocytes, on average, have 8 to 9 oocytes per cycle, and most aim to have about 20 oocytes. So they do, on average, 1.5 to 2 cycles per patient. So this brings me to my conclusion. Deferring motherhood, it is a societal problem. I fully agree with that, but the treatment, what we now call social freezing, I think it's a medical treatment. It relates to fertility and has obstetrical implications too. And like it's been also said by the previous speaker, it cannot be easily countered. There's nothing we can do in the policy that would change women's opinions, especially it's only growing. It's a global phenomenon. The alternative women have is oocyte donation, but it has its limitation. First of all, we see more and more women doing oocyte donation for that particular reason of age-related fertility decline, and that treatment always relies on a third party with all these problems of sometimes scarcity of donors, and also the problem of anonymity and so forth. So this autologous oocyte donation or banking really provides women the opportunity to independently preserve their fertility, and I think it's the second biggest breakthrough for women reproductive autonomy since oral contraception. In our pioneer cohort, we see that they're mostly single and highly educated. We need to see in the future if it gets more common, if it stays like this, or other women will join in and do the same. We see the motivation is mainly in insurance and in order to buy more time. Many candidates, however, are too late, but we see a decrease in the age of our candidates, so maybe something is going to happen even more in the future. And I also think that it's very important to have an adequate screening and counseling of the candidates so that they really know what they are doing. I thank you very much for your attention.
Microphone. Please.
It's coming.
Okay.
Thank you, Dominic, for this beautiful presentation. I have two questions for you. One is more medical. I noticed that your patients, they would go first to IVF with fresh oocyte, then use their own cryopreserved one. So what's your medical counsel when someone comes at 42, 43 with store egg from 36 or 37? Do you actually counsel them to use their own fresh eggs first?
No, it's very true that it very much depends at the age when they return what to do first. If we would come back at 40, 39, I think, and you do this reserve test and you see these reserves are acceptable and stimulation or IVF is feasible, then yes, of course, IVF first. And they can use their frozen eggs maybe for a second child. But of course, at 42, 43, when the chances with any kind of treatment with own eggs is very low, you can, of course, consider to freeze them immediately, thaw them immediately, these oocytes.
Right. Then I have another question. I see that career is really given as a reason for delaying motherhood in a very small percentages of women that come to your clinic, right? It's 4%.
Yes.
And most of them say they didn't find the right partner. So that seemed to be a little bit at odds with what Thomas was saying about countries where education is very high. So I would assume where the jobs are also good for women, those are the ones where more delayed motherhood. So does that mean that women with higher education have a harder time in finding partners?
It's possible, or it's just hypothetical, of course. Maybe they just start looking for a partner or start to settle later, and then more likely to be confronted with being single at the time where they're really in trouble biologically. But it is very interesting to do a study on this topic. Maybe if you look at universities in my country, I don't know, I think it's everywhere in Europe, for many courses, the females are in the majority. So I think it used to be a time where there were no women in university, but now the vast majority of students are female. So it's possible there's a mismatch going on between the women, which are highly trained, and they don't find a partner which is of the same intellectual level as they are. And actually, many of the patients say so in the consultation. So I'm sure they can easily find a partner, but they're just not happy with what they can get. That's what I think.
Dominic, is there a minimum conditions of ovarian reserve, anti-follicular count on anti-Mulleriana level to do these techniques in the patient?
I didn't really understand the question.
A minimum conditions of ovarian test reserve.
It's very difficult to set minimum standards for when is acceptable to start stimulation or not. If we are in doubt, we clearly inform the patient that it's not very certain that we will get a good number of oocytes, but ultimately the real test of an ovarian reserve is the ovarian stimulation itself. So then we say, okay, you start with your ovarian stimulation, and then just when we are ready, before triggering, depending on the number of follicles we see, we will then discuss it, whether or not we'll proceed to puncture or not, because the main cost of the treatment is the retrieval, the freezing, and all. So they can still then have an ovulation and lose 2 or 3 follicles, nothing happened. But then in the end, they know for sure they have a limited reserve, and we give them always a chance to start, unless they're 40 or plus. So if they come at 40 and they have a poor response, then we say, okay, there's no quantity, there's no quality, so we don't start.
Thank you. Any question? Laura? Please.
Thank you, Dominic, for a very nice presentation and for a very nice new definition of social egg freezing. I really like it, age-related fertility decline, banking. I think it's really fantastic. I have a concern about the insurance. To say that egg freezing, it's an insurance, I think it's not really like that. First of all, it is true that if you have an insurer, you don't care if your house is going to burn, but you want to be sure that in case it's going to burn, you will be paid, you will be reimbursed. That's completely different with egg freezing. With any number of oocytes, you will never be able to guarantee to any patient with fresh oocytes, and exactly the same with cryopreserved oocytes, that woman will get pregnant with this. So I think insurance, it's a little bit confounding for the patient.
Yes, I fully agree, but the insurance, I think, is mostly mental, psychologically, which is dubious, of course. I'm not saying that oocyte freezing are deficient, but we've done a follow-up study, which we'll present at ESHRE, of our first cohort, and there we see that the vast majority of women thinks now, today, that they're less likely to ever use these eggs than what they thought at the time they froze them. So you would expect many will regret have done it, because I think it's 2/3, and 1/3 will never use it. They say it already now, and just frozen a few years ago. But 97% is extremely satisfied that they've done it. So I think for the last few years, these women must have feel very good about it, although they know with every year that passes, the chances of not using it increase. I think the insurance is more psychologically. They feel that they've done something, but I know insurance, if it would be an insurance like this for your car, you wouldn't be happy with it.
Yeah, exactly. The problem is also maybe the opposite, is that knowing that you have frozen oocyte there, I'm completely, of course, I'm positive for egg freezing, but I want to see all the aspects. So I think that if you know that you have these oocyte there, yes, in the bank, you may postpone even more your motherhood,
yes,
because you know that you have time now.
Yeah, but that's another finding. That's another finding from our study, because we compared the attitudes, the way of life of those who did freeze, because I showed you 55 started freezing, 45 decided not to freeze. And we just follow them up and we see what's the difference in the way they live. And we saw that the percentage having a steady relationship in the two groups are identical. The percentage of women actually starting active, trying to get pregnant was identical between the two groups. Those who experienced infertility was identical. So in all these parameters, which would possibly express a change in behavior, we saw no difference in those who did freeze and those who did not freeze. And the surprising thing was, those who did not freeze also would advise others to do so, even though they themselves did not freeze, because the main reason they did not freeze was because of they thought the chances were too low for them because of their age and their ren reserve. So that's the main reason why they did not freeze.
Thank you. Any question?
I have a small question. One of the main concerns of your potential candidate freezers, up highest in one and second in the other one, is the assurance that the treatment would not have a negative effect on their future fertility. I'm quite astonished by the ranking it got. Do you have any idea where this comes from? Why do they fear that the treatment might have a negative effect on their future fertility?
Partly probably because they have a strong desire for a child and they don't want to, they say probably if I do something, at least I don't want to do anything bad. So,
yes, but why do they think it might be bad?
Secondly, from my experience and consultation, many women often think that if you stimulate and you get more eggs, out at once, they will have early menopause. So you take out 12 eggs, it means 12 months early menopause, because there's a misconception among the lay public sometimes. Okay. So that's what they sometimes think, that it is you harvest the eggs, which you then lose in the future. I think maybe this may explain. So yeah, but I think it's just a misconception in the public.
So this is something that could be amended by better education in a way.
Yes.
Okay, thank you.
Sophia?
Thanks for your presentation. Just 2 simple questions. Can you tell us how many women have used oocyte cryopreservation in your center per year? And it may be too early to ask, but how the percentage of women that come back to then try IVF?
Yes, the thing is, there's only one who came back. So we started in 2009. There were like 13 that year. In 2010, 50, and then from that it's gone up. So in 2012, we had our first one coming back, but our eggs were frozen for 2 years. So the follow-up is really short.
Yeah,
I think in the next coming years, we'll have many more. And those that come back, there are now a few trying to conceive with donor sperm. So this is, those who really wait for a partner, of course, have to wait longer before the relation is stable enough to go for children. Those who, the first who comes to thaw them are those who use donor sperm.
And how many per year are freezing their eggs in your center? More or less?
The number, so the candidates, the last 2 years was each 90 candidates, and just over half did it. So about 50 patients a year, but they do multiple cycles.
Okay. Thank you.
Okay. Thank you very much.